let's take a moment to talk about the side effect that occurs during our treatment paradigm. So if you recall, we have three different paradigms that we are considering. The first is diagnostic, the second is treatment, and the third is rehabilitative. We're going to hang over here in the treatment paradigm. We are going to place ourselves in our weeks 1 through 7 for our head and neck cancer patient with receiving chemo and radiation. And we are going to specifically hash out and talk about the side effect that impacts patients' quality of life forever, xerostomia, known as dry mouth. So what do we know about xerostomia? We know that xerostomia in our patients is going to be a lifelong side effect when they are receiving 60 to 70 total grays of radiotherapy. How about the start and the onset for our patients? Well, at the levels of 10 to 20 grays of radiation, so stay with me for a moment, let's do some math. 10 grays or less of radiation is usually going to give our saliva glands a minimal effect, okay? If our patient receives 5 days a week, so 1, 2, 3, 4, 5. This is week 1. Each of those weeks, on average, they are receiving a total of 10 grays of radiation. So that's going to be on average day 1, 2, day 2, now they've received a total of 4, day 3, a total of 6, day 4, a total of 8. Day 5, by the end of week 1, they've received 10 grays of radiotherapy. This is on average. Your radiation oncologist will have your patient's specific mapping down to the decimal of the number of grays that they are going to receive. So if your patient receives the first week of radiotherapy on average 10 grays to their salivary glands, now let's hang with me, to their salivary glands, they will begin to feel either no effect or the tiniest, slightest little change. Now, there are 3 paired salivary glands. There are the parotid region, a left and a right, the submandibular left and right, and the sublingual up in the tongue, a left and a right. Depending on your patient's field of radiation, they will have different levels of dry mouth. So if we start to move into week 2 of treatment, during week 2 of treatment, our patient is going to, again, on average, have 2 grays of radiotherapy. And so now they're at 12 grays on Monday, 14 on Tuesday, 16 on Wednesday, and boy, I skipped a day. That's what I love to do. 12 on Monday, 14 on Tuesday, 16 on Wednesday, and 18 on Thursday. By Friday, they've received 20 grays of radiation, and now we're going to continue through week 3, and we're going to get around 30 grays by the end of week 3. During this range, 10 to 30, so at 10 to 30 grays, it is believed that we are starting to see some of the partial and kind of possibly, considering that loss, where our patients are going to say, I'm starting to have some dry mouth. If your patient is receiving radiotherapy to the bilateral neck of the sublingual and submandibular, they are going to be starting to tell you this right around the ends of weeks 2 or 3. By the end of week 4, the patient has likely had, and again, consult your radiation oncologist, around 40 grays of radiotherapy. At the 40 grays of radiotherapy, the findings are that here we are looking at a long-term loss of salivation glands, and then as their treatments continue through weeks 5, 6, and 7, they are continuing to lose their salivary glands and production. Now, it's sort of this thought process of, well, can I get it back? And the answer is no. The radiation damages the salivation glands. It actually changes the genetic makeup of these salivary glands, and it causes a change in their overall size of salivation glands, as well as a disorganization in the structure of the saliva gland. So when our patients are asking us, what do we do about it? We compensate. We take small sips of water throughout the day. There are products on the market that believe that sometimes they can help patients. In my experience as a speech pathologist, the honest truth is that there has never been one product that all patients have been happy with. There have been a little bit of each product that if they try it during certain, for example, if they know they're going to walk into their doctor's office and they want to spray a little bit of biotin, perhaps that's helping them. The best thing overall, though, is going to be their sips of water. Now, I want to pause for a moment and talk to you about a couple other factors that I like to encourage. I like to encourage that they carry a bottle of water everywhere, and I am always encouraging that my patients are going to be keeping their oral cavity clean and their mouth clean. I do discuss with my patients the three salivary glands, and I also discuss with them the role. So the parotid gland, which is going to be right in here, makes a really thin saliva for them, kind of a watery, while that submandibular and the sublingual are going to create more mucus and a lubrication in their mouth. So if some of these salivary glands are spared based on the modulation of their radiation therapy, then sometimes these patients will have improved outcomes or quality of life. So before your patient starts their treatment, they want to discuss with their physician what's going to happen with my saliva glands, where are the fields of dosing and radiation, and some centers are sculpting or sort of changing the way in which they are treating the patient to try to spare some of these effects of their saliva. So we do understand the weeks in which salivation will be impacted. We understand that this is a permanent loss. It does not return. It actually worsens. Our goal is to compensate, educate our patient, and be honest with them. The most important thing you can do as a therapist is be honest with your patient. The higher the dosing of radiation to the salivary glands, the longer the side effects, the earlier the side effects, and that patient is going to experience long-term side effects. So that's a summary in terms of salivation glands. The challenge for the saliva glands is we know that xerostomia starts around, we're thinking somewhere around the ends of weeks 2 and 3 of their treatment, and it is going to continue into that rehabilitative lifelong circle that we are going to change in this paradigm. Xerostomia is impacted for the rest of their life. They will have dry mouth for the rest of their life. Our goal is to help them compensate and find tricks to it, as well as teach them that the structure and the genetic makeup of the salivary glands has been damaged. It is not returning. A very challenging quality of life side effect.